Good afternoon, everyone. We are ready to start our webinar today for Semester 2 of the Performance Driven Academy. If you haven't yet, there's a couple of links to our surveys in the chat box for you that you can fill out quickly and give us some of your feedback. Today's topic is contracting and negotiation, and we're excited to give you some really critical information around those topics that hopefully you find helpful along with the tool that we'll be sharing with you later today. The Performance Driven Academy is brought to you by the Managed Care Technical Assistance Center, which is a partnership between the McSilver Institute for Poverty Policy and Research and CASA, the Center on Addictions. I am Brianna O'Connor. I'm the Associate Director of CCSI's Center for Collaboration and Community Health, and CCSI is the upstate New York partner for MCTAC. A couple quick reminders. This is sort of your last chance to take our end of semester 1 survey that tells us kind of how you did over the course of semester 1, how we did, gives us a chance to get some feedback about how you feel about it so that we can modify things for semester 2. It really does take only about 10 minutes, and we are asking that every individual complete it, not just each agency. Webinars are recorded, and you should have received the materials for this webinar ahead in your email from pda@ccsi.org, and they're also posted on the MCTAC website. Anytime throughout today's presentation, chat in some questions or comments, and if you send them to all panelists, we'll see them, and there should be time, hopefully at the end, to ask our expert speaker a couple of those questions. As usual, just a reminder from participating in semester 1 and kind of moving forward into semester 2, we hope that some of these things are resonating for you, that you're really seeing a path to become better positioned to know your cost, your quality, and your impact. You have seen some steps through some of the tools that we provided for how to integrate some of that knowledge within your organization so that it's more than just the folks attending your work group sessions and attending these webinars that are able to benefit from it. And hopefully the tools and resources we're providing you are supporting you in those efforts. And again, if there's more you need somewhere, if something doesn't quite make sense, we're always open to your feedback either via our email address or on any of our feedback surveys. Hopefully you're seeing you'll see the benefits of these things, but we'll also be providing you the summary of the evaluation feedback so that you can see that kind of concretely with data, and also we'll have certificates of completion for semester 1 coming soon and semester 2 later on this year. This is our graphic of all the components that come together to make a performance-driven organization, with the navy blue background being the culture that we talked about early on in semester 1 that really forms the foundation for all of these processes and infrastructure components that need to come together. Today we'll be focusing specifically on the process of contracting and negotiation. Our roadmap graphic here, just to show you kind of where we've been this semester. We've talked about revenue cycle management and financial best practices. A couple weeks ago we had a webinar around corporate compliance, security, and privacy, which is of course related to some of the contracting and negotiation pieces that will be covered today. And then coming up in a couple of weeks in mid-September are our in-person sessions. You should have received links for how to register and the dates for those. They're being held in Albany, Rochester, and New York City, so hopefully there's one close to you, and those are more information about those is coming out to you and has come out to you. If you actually bring some key pieces of your financial data, there'll be an opportunity in the afternoon of those sessions to have sort of one-on-one sessions with some of our financial experts to really talk you through what your data is showing, what questions it can ask, and how to use your data within the tool that we have provided for you so that you can actually get some of that kind of one-on-one technical assistance. So we're excited to offer you that. Coming up later in the fall will be the last section of our academy, which will be around leadership practices to really support all the changes that we've been talking about throughout the year. And with that introduction, I would like to turn over the content of today's webinar over to Dr. Joe Sankaitis.
Hi, thank you very much, Brianna. Good afternoon, and I'm really delighted to have this opportunity to, I guess we're not really having an ongoing chat like at this point, but to be able to share with you my perspective about what goes into contracting and some negotiation regarding the development of agreements between community-based organizations and value-based payment entities. My background, I'm the Chief Medical Officer for the Monroe Plan for Medical Care and also Your Care Health Plan. I've been in that role for 21 plus years in terms of Medicaid and in managed care prior to that. Regarding Medicaid, I'm a member with the New York State Department of Health Medicaid Evidence-Based Benefits Advisory Committee. This group is a group that meets in Albany periodically to review what's currently being covered by Medicaid and really being able to assess, looking at the literature, looking at what's going on as to what's effective care, and then also trying to identify new approaches to care delivery and also services that aren't currently covered by Medicaid. And again, these get reviewed in depth, looking at systematic reviews and meta-analyses to see what the science is behind it. And in that case, we make recommendations that it ought to be covered, and hopefully the Department of Health in its Office of Budget will approve our recommendation. I'm also been involved with the New York State Department of Health Measures Support Task Group. This looks at the quality metrics that are out there that have been proposed or are evolving for the various value-based payment approaches. I've been a member of the Medicaid First 1,000 Days Task Group, which is still ongoing, but it's really been interesting to be able to bring to the table not only the usual players within Medicaid, the New York State Department of Health, the Office of Mental Health, and also OASAS, but they've also brought to the table the Department of Education and the regents, and it's opened up people's eyes as to how what we're all doing affects not just simply health care, but everything else. And Your Care, our HMO, has one of the New York State Department of Health value-based payment pilots. We have that in Erie County. It's with the Greater Buffalo United Accountable Care Organization, which is really a practitioner-led group and not purely a system-led group. And it's been really interesting to see how things have evolved when you have practitioners that are on the hook for some risk and quality metrics and how they move forward with things. So, learning objectives for today. First of all, if you are expecting to have a seminar with Dr. Chester Karras, he's the guy that's got ads in all the flight magazines. You pay a few $1,000 to come to my 2-day seminar, and I'll make it a master negotiator. That's not what you're going to get today, but it's more or less, I think what we need to recognize is, whether you're a community-based organization or an MCO, we're all in this together. And it's really got to be something that ends up being a win-win for people and not a win-lose thing. We're all taking care of highly vulnerable individuals, and our objective really is to make things better for them. So what we want to cover today is a few things here so that you better understand what's the engagement for a community-based organization within a value-based payment agreement. How do the CBOs fit into a value-based payment arrangement? There's strengths that you as a community-based organization probably bring to the table that the MCOs, ACOs, PPSs, whatever, would love to have, but they just don't have within their purview. The other thing is what to be looking at for contracting strategies, and this is more not to be a win-lose type of situation, but it really gets into what it is that you're bringing to the table that is really appealing to the people that you want to contract with so that you can come together to a mutually beneficial relationship and really be able to execute an agreement that's meaningful and will make an impact. And then finally, issues to address when contracting. I hate to say it, but the devil's in the details, and you really need to think through various things before you sign on the dotted line. And again, these are going to be at high level, and we have a tool that has been made available to you, and it might be fairly useful for you as you're going through this process. So what happens with community-based organization engagement in value-based payments? Well, If you go back 10, 20 years, I think a lot of organizations similar to yours were pretty much tied into grant funding, and I hate to say it, but there wasn't a ton of accountability for a lot of groups where they would go to a foundation or to someone and say, you know, we're wonderful people, we do great work, show us the money here, we'll be able to do wonderful things with you. That's different when you're talking about value-based payments. This is now going to be, I hate to say it, but a business arrangement, but I think a good one in the sense where it needs to be a partnership where you need to be able to have flexibility because things do change. As you all know and have experienced over the past several years, nothing stays in stone, particularly when you're dealing with Medicaid from New York State. You've got all sorts of things that go through the legislature, the governor's office, programs change. So having a value-based payment arrangement and an agreement really will allow for flexibility, particularly if you have a true partnership with the entity that you're contracting with. Also, it allows you to be more innovative in providing services. There's an incredible amount of learnings that are going on in terms of how do you best do something and provide a service. And again, through a partnership, again, that's where both parties, you and the entity that you're contracting with, can really identify how you might be able to be doing things better. Like we've seen it with our value-based payment arrangement with Jabaco. It's been incredible to see when physicians are on the hook for money, they really are interested in what's going on with pharmaceutical costs, how can we be smarter with various services, what do we do to address people with substance use disorder because they're driving our costs. I mean, it's a whole new world. And again, your contracts may have a shared savings component. That's what we have with our value-based payment pilot. And again, that's a whole new world, and I think we're learning from that. The other thing I want to point out here is that Tier 2 and Tier 3 CBOs may implement a social determinants of health intervention to help satisfy the Level 2 and Level 3 arrangement requirements that New York State has. However, CBOs are not obligated to assume financial risk when you do enter into a value-based payment arrangement with an entity. And I think that's really helpful to understand. I don't think that anybody's out there trying to gouge you to provide services totally for free or else lose your shirts, because frankly, it's a real challenge, and a lot of organizations are not-for-profits. They don't have huge fund balances, and it's a challenge. And I think that's part of the conversation with the entities that you contract with. The other thing that's interesting is that CBOs may be contracted to support more than one value-based payment arrangement. So an MCO might have one value-based payment agreement with one health system, and they might have a different one with a different health system, but yet the community service that they need is universal. So you could find yourself interfacing with more than just one actor as it goes. And then the other thing to keep in mind is that if you're a Tier 1 CBO, your organization provides non-Medicaid billable social services and thus is not required to become a Medicaid billing entity. I don't know whether you've gone through that process, but at least what I'm hearing from physicians is it's been a nightmare because of the final rule out there requiring anybody that's going to be paid by Medicaid to get a number. So good luck with that if you have to do that. What do we as value-based payment contractors truly value? And I think what we're looking for is that we have community-based organizations that are involved within the communities that we're serving, and that you really understand the causes of poor health in the populations that you serve in that locale. What we're looking for, too, is that the partnership that we develop with a CBO be one that provides value and it aligns with our goals and our objectives. Now, on my end, my organizations are not-for-profit, so I'm not on the hook like having to get share prices up or giving out dividends. And our mission is to really enhance the care for the underserved. And I think that's an important thing, that when you do develop a partnership, if you've got common values, that makes it all the more robust and has a higher probability of success in that situation. The other thing that you got to keep in mind is that I, as a MCO, am looking for interventions that can make a measurable impact on the population that I serve. One of the things to understand is that the managed care organizations in New York State that serve Medicaid are on the hook for quality metrics. And a lot of them get into not only processes of care, but outcomes of care, both in the physical health world, also the behavioral health world. In fact, for some of the HARP arrangements with the state, they're looking at such things as encounters with the criminal justice system, all sorts of things like that. So what we're looking for is to be able to enhance our performance by working with you as an entity, and consequently that translates into greater premiums that come to the direction of the MCO. The other thing that can happen here is that community-based organizations, like we're looking for some that can subcontract with other CBOs and coordinate social services for us. So you might have, you as an entity might have relationships with some other community-based organizations that you work with on an ongoing basis, and you work very well with them. Bringing that to the table in terms of your arrangement for the value-based payment also brings a lot of strength to that. And then again, the other thing that we're looking for is being able to develop interventions that are flexible, and can they be scaled up as savings are being recognized from the activities. So how do you get involved with this? Okay, we're talking about going out there and contracting with an MCO or a PPS or whatever. Number one thing is you really need to understand what are the needs for the community that you're going to be providing the services in. It's important to know what the demographics are, how many folks are there potentially that will require your services as part of this arrangement. You also need to know your key community partners. And with this, and this includes not only the PPSs, or they're also known as the DSRIPs, I think, but that's going to go away, I think, in another year or so. Managed care organizations, you've got provider systems and hospital systems and other CBOs. But the more that you can understand what are their needs, their pain points, that really positions you well to be able to come up with a solution that would be appealing to them to want to work with you. The other thing that you need to do is learn and understand the local value-based payment level 2 or 3 arrangements. Because what that gets you into is New York State, again, has got metrics out there that deal with total care costs, integrated primary care. They look at maternity. They have bundles for that. Care for HIV/AIDS, the health and recovery plan, and also managed long-term care. And to be able to understand what are people measuring, what are they being held accountable for is really, I think, an eye-opener for you, but also, again, positions you from a position of strength, being able to better understand what your future partners' needs are. The other thing is, again, use data to determine what social determinants of health interventions are really needed. What's a real turnoff for anybody that is having a conversation with a potential partner is if they're clueless as to what the degree is, say, for example, of homelessness within a given community or some other need. that really doesn't play well. But if you do your homework, you go in, you say, look, I know that in this city, we've got this number of folks that are below the poverty level. You've got this number of kids that are on the school lunch program. This stuff really adds a lot, and it really shows that you really are professional and really an expert, like, for the field you're in. The other thing we're looking for is how can you help the value-based payment entity leverage existing resources. Again, a lot of what we find ourselves having to do is there's no new money coming our way, but we've got to make do with what we have, and how do we make them better, how do we do things smarter, and that's part of it. And then ultimately, your organization needs to develop a value proposition to the entity that you're hoping to contract with. You want to be able to share with them in terms of, by contracting with my organization, we're going to be able to give you this type of a review, a return on investment. This is how we're going to impact what your needs are. It has to be something that's very tangible, that someone can not only feel from the heart, but they're going to have conversations with their finance people. And it's very difficult to go to a CFO of a managed care organization and say, look, we need to contract with these guys because we think they're going to do great stuff, but if I can't articulate what the return is going to be, I'm going to be sort of hustled out of the office, and come back when you can get me some numbers is really going to be the answer that I'm going to get. So you got to keep that in mind. Value propositions are important. Then how do you develop your value proposition? And again, this is your compelling argument as to why the value-based payment contractor should contract with you. You need to be able to articulate what services do you provide. And I think what you need to do is really showcase the services that you are head and shoulders better than anybody else within the community or the area that you're going to serve that you do. It's really important to be able to do that and select where you can really succeed, because the last thing you want to do is get into an enterprise doing something that you've never done before, and then if it starts failing, that doesn't bode well for you for the future. You're going to have ill feelings between you and the partner. So you really want to go with your strong suit, let's put it that way. You need to know who are your community partners. Who's out there that you can count on, who have you worked with, who have you coordinated with, and also it still also includes some of the other folks out there, the PPSs, the health systems, and the MCOs. The other thing that you need to know is what you're proposing to do, what's it going to cost you to do that? You really don't want to get into an enterprise where for every service that you provide, you're going to lose money. You're not going to be around in existence too long thereafter. So you really got to figure out, okay, what are my costs? And that gets into what your administrative expenses are, what are your labor costs. I mean, that's usually a huge part of it. You get into such things as fringe benefits, and that you need to take that into account when you're trying to put together a proposal that's a business agreement with somebody else. The other thing you need to find out is what's the community need for what you're going to be doing, and how does that overlap with the MCO or the value-based contractors population that's being served. So, a standard one out there is homelessness. Housing's a big to-do. There's really good data out there that if an individual is homeless, their costs of health care are extremely higher than people that have a stable housing environment. And again, being able to better understand how big of an issue this is, and then how does it overlap with what the MCO is struggling in. For example, homeless folks tend to use the emergency room quite often, particularly during the winter months because it's nice and warm, you get fed, and I've heard stories from Boston, from Massachusetts General, where people knew that there were individuals who would come in and claim they're going to be suicidal and knew that they'd be admitted for 4 or 5 days and they'd have a nice warm place to live, great food, a nice view of the Charles River. I mean, these are things that you got to really be tuned into. And then the other thing you want to know is how does the service that you're going to propose to offer and your geographic reach provide value that's tangible to the arrangement and also the Medicaid population that's going to be served. And then ultimately, you can't really know that you're doing well without measuring, and it's important that you need to track and measure the outcomes that are pertinent to what you're doing and ultimately to your new partner to support this value proposition. So, contracting strategies. Now, CBOs, like you can support value-based arrangements by the following. You can be contracting directly with a managed care organization to support a value-based payment arrangement. There's still out there MCOs that have case management programs, and this is where that might come into play. However, with the advent of health homes here in New York State, that's probably not as big as it used to be, but there are subpopulations that don't qualify for health homes, for which you do need to have some community-based organization support, so that could be important there too. Also, contracting directly with a managed care organization to support multiple value-based payment arrangements. So I, as a health plan, can be having 2 or 3 value-based payment arrangements in a given community, say with one hospital system, the other hospital system, some other independent group. They're serving the same population typically in the same community, so there's going to be fairly uniform needs that people will run into. Again, I hate to pick on housing, but that's a big one that's going to be universal throughout the community. If it's a big problem for one value-based payment entity, it's certainly going to be there for the others. Also, subcontracting with a value-based payment contractor. So again, it doesn't have to be an MCO, but it can be with a hospital, an individual practice association. Monroe Plan is an IPA. It's one of the oldest ones in the country, but we own our own health plan. An accountable care organization. There's several of them that have sprouted up. And I mean, not only like just on the Medicaid side, they're there for Medicare too. There's several of them out there too, or other entities. And then the other thing for contracting, there could be multi-tier community-based organization partners contracting directly with an MCO to support the value-based payment arrangement. There could be a consortium of people that get together and kind of say, look, you know, we might offer one proposal to this value-based payment contractor where we're working as a team, and you're going to offer the service that's your big strength. I'm going to offer the service that's my big strength, and combined, boy, it's a home run for them, and how can they ignore us? So I think that's another approach to take. Again, as I mentioned previously, CBO contracts are not required to include risk, and that's financial risk. They may be structured. You could have it as a payment for services rendered, and there's no risk-based component to it. Then you have some others there where you can have an upside only with no downside risk. I think the state of New York calls those level 1 or level 1 arrangements. Where if there's savings achieved, you as the contractor with the value-based payment entity will receive a portion of the shared savings, or if losses are incurred, you don't have any of the losses. Quite often, in order to get the savings, you have to achieve certain quality metric performance levels, and it's part of value-based payments. And then you finally have the upside-downside risk, and this is really, really interesting, where if savings are achieved, you as the CBO will receive a portion of the shared savings. And again, this is going to be how you set up your agreement, how you want to do that. And if losses are incurred, potentially you would take some degree of a loss. What a lot of programs have is that if, for example, there would be a loss and the contracted entity to the value-based payment entity has delivered on all their quality metrics, if you have it in the contract, it could be where then you're not going to be assuming any of that loss. Similarly, like if you got savings, but if the quality is not very good and things aren't going well, you don't necessarily are going to get all of the savings either. And again, that's part of your contract development. What are the metrics? How are things going to be allocated in terms of shared savings, shared losses? Again, the CBOs may be held to performance measured standards by the contractor or the MCO in order to continue the agreement. I think they're going to hold you to performance measure standards throughout the entire agreement. And well, that's only fair because, again, you need to know what is it that you're getting. And, again, the entity you're contracting with wants to make sure they're getting a return on their investment in terms of working with you. So issues to address when contracting, there's a whole slew of them, a contract term, contracting parties, scope of the project, how protected health information will be handled, what's the service area, payment methodology, and then reporting and data collection. So as I mentioned before, there's a key items for contracting development worksheet that was distributed prior to this, and I'm sure that it will be made available to you afterwards. But what this really is it's really providing you with a framework to consider and really answer these various bullets that we have here, because it's going to be important for you to be able to address these in order to have a very workable and a satisfying agreement. So the contract term, what you need to call out is what's the effective date of the contract and when does it end? Again, this is something that I think it seems obvious, but there are times where there have been some folks where they're clueless as to, well, how long are we having this arrangement and when does it end or when do we start it? The other thing to keep in mind is that there are contracts that will automatically renew after an initial term, and these are considered evergreen agreements. Quite often they'll be put into the agreement that either party can terminate the agreement without cause by giving so many days notice prior to a given contract termination date. So if, say, you've got an agreement that would be ending on December 31st of 2020, if it's got the evergreen set up, and if no one's had any active discussions, then it might have that either party can notify the other that they're no longer going to renew it 90 days prior or 180 days. Again, that's part of the negotiation. Contracting parties. This almost seems too obvious, but it isn't. Like, you need to know with whom you're contracting with, the MCO or the value-based payment contractor. It's amazing there are a lot of organizations out there that have multiple entities through which individuals will contract. And some of it gets into IRS and tax law issues. There's a lot of not-for-profit folks that if they're getting into what might appear to the IRS being a for-profit enterprise, there is, if you talk to some accounting folks and or legal folks, a risk of having them do some negative things towards your nonprofit status. So there's some entities that are not-for-profit that have set up limited liability corporations that will pay tax. so that it keeps the IRS and their people at bay and not looking for mischief in terms of the way that you're set up. But you need to know and really be explicit with whom this agreement is, and you need to use the legal names for each of the entities in the contract. It can't just be like, for example, my organization, Monroe Plan, it's Monroe Plan for Medical Care. You got to have that and Inc. at the end of it too. So that's all part of the details. Scope of the project's important. So what you need to describe is the project implementation. If there is a timeline that needs to be followed, put it in the agreement, because it's the quickest way. Not having one is the quickest way to get to a lot of misunderstandings and that, because quite often there might be a ramp-up period that's important for you to go through in order to succeed in the project, and it's got to be articulated in there. You need to also be very clear as to what are the services that will be provided by your organization. One of the biggest problems for a lot of entities that get into agreements is what they call scope creep, where all of a sudden what you thought you were going to be doing at the start of the agreement, 9 to 12 months later, the animal's looking totally different because other things have been piled on, and it's sort of like boiling a frog by turning the heat on the pot of water very slowly, and they'll sit in there and they won't jump out, and then they'll get boiled. It's the same thing here. You need to describe what services will be provided. And then you also need to articulate who is it that's going to be getting your intervention. Who's the targeted population? Is it all the members in the arrangement for the MCO or the value-based contractor? Or are there going to be subpopulations that are going to be the focus of your activities? So, for example, you could be contracting with my MCO. We have a mainstream Medicaid managed care program. We have a health and recovery plan. Is this service going to be for the HARP members only, or is it going to be for everybody that is one of my enrollees? So you need to be very clear about that. And then the question is, okay, so you've identified who it is that's going to get the service. How's anybody going to know who gets the service? So you need to articulate in the agreement, will it be the MCO or the value-based payment contractor? Who's going to identify the targeted members and then refer them as needed to your organization to do its thing? It's a big to-do, and you have to get into such things as data integrity. I think that's an important thing to put into when you're talking about implementation timelines, wanting to make sure that the reporting is running smoothly, because it's amazing to find the glitches that can happen through IT systems and improper coding and all that. And then the other thing is, how will you evaluate or measure your performance? Again, this is important because it's part of your relationship. You've come in with a value proposition. You want to be able to demonstrate, hey, look, things are really going the way that we said it would, or if there are issues, hey, listen, we need to work together to solve some issues here, and we need your help. We'll work at it so we can all be successful. Then you get into this wonderful thing called protected health information management. Most of the entities that are doing value-based payments are going to be MCOs or people that are dealing with healthcare information. So the agreement has to have content in there that if your organization is not a covered entity, and I don't know whether you've gone through this in your previous seminars, but a covered entity could be a health plan, a healthcare clearinghouse for claim submission that's electronic, or healthcare providers. They're considered covered entities, and really you don't need to have an exclusive business associate agreement. But if you're not a covered entity, you have to execute a BAA with the NCO or the value-based payment contractor. Because, again, you're dealing with protected health information. Violation of this has gotten to be a big to-do with some of the penalties involved. They talk about prison time. I'm not aware of anybody per se that's gone to prison unless it was used for fraudulent reasons or for things that were totally off the reservation. The other thing you want to look at, too, is the geographic and service area. What are the areas where your intervention will cover? So a lot of health plans span multiple counties, so you need to call out, our organization will provide the service that we're contracting you with these 3 specific counties, and you need to call it out because otherwise then you'll get into, again, the famous scope creep. Okay, well, you're in this county, but this other one is nearby. We could always, have you do a few of those folks, and then that starts to have some challenges in and of itself. So it's good to have it out there up front to begin with. Payment methodology is also very important. So you really want to know, how will your organization get paid? Is it going to be a lump sum that's going to be given to you up front annually or something? Is it monthly payments, quarterly reimbursement? That's something to be worked out within the agreement. And then the other thing is, because this is value-based payment, are payments tied to specific measures and outcomes. So again, this is something you negotiate with your partner as to what are important metrics for you that will be something that you can report on, be able to act on, and then be able to demonstrate that you have delivered. So it could be something like the number of referrals made, number of visits or contact hours, number of patients who were successfully reconnected to their health care provider. Again, it's going to depend on what service is that you're giving them. It could be something like what's the duration of people being in stable housing if it's having to do with housing, or dealing with somebody where the criminal justice system is involved. What's the rate of that? Has that gone down? So things of that. But again, that's something you can negotiate with your partner. And then reporting and data collection. How often are the reports due? I mean, quite often, a lot of MCOs, when they do delegation of services, they will be looking for reports at least every 6 months or so. It could be more frequent. If you got something that's daily and it's easy to get to, great. But you got to remember that if you're going to be doing reporting, included in your cost, you got to figure that out, because you don't want to get into something and then find out you now have to invest $500,000 in some software or IT system to be able to report what you've signed on the dotted line to be offering to your partner. So how often are the reports due? What data points are being collected? And really, how will people that are served in the intervention be tracked? I think that's part and parcel of all this. So I've gone through most of my spiel here, but I think the question people struggle with, okay, so what do I do next? And here's some takeaways or some friendly advice. Before you get going with any proposal to anybody, you as an organization have to get your folks together, have an honest internal discussion to really identify what services your organization does best. It's what's in your wheelhouse. What is your strength that you're not afraid that if you go forward with this, it won't fail. Like, you want to succeed. So this is an important thing. You don't want to get into stuff that you've never had any experience with or whatever. You want to be able to put your best strength forward. The other thing you need to do is, who might be your potential value-based payment customers? Who do you want to offer this service to? Who do you want to contract with? And part of it gets into not just who they are, but find out who they really are. Like, what are they about? What are what's their organizational mission, vision? Because that's important. Chemistry is important. If you get organizations that are at cross purposes, it's not a wonderful situation to find yourselves in, and it's better to find out before you have the marriage than after the marriage. Divorces can be kind of ugly in this situation. And then the other thing is begin using the contracting development worksheet as a guide. Again, it's a framework for you. It's not got everything in it. I'm sure there's going to be nuances and little things there that that'll pop up, but at least you need to get the core stuff down, and at least this gives you the framework for that. So.
Thank you. I'm happy to take it back over from you. Thank you so much for all of that content. I think that was really helpful and gave everyone a really kind of concrete set of questions and follow-up things that they can be asking. While I'm doing just the last couple minutes on reminding you guys about the in-person events, please feel free to chat in any questions that you have for our speaker, and we have a few minutes to answer some of them, hopefully, if you have any. While you're thinking of your questions, the dates and the locations of our in-person events are here. Just another plug to remind you to please register individually for those events so that we know how many lunches to buy for everyone and how much coffee to have. We need to know who each person who's coming, not just your agency. You should have been sent those links, and I'm sure you'll get another reminder later this week. And any questions that anyone has, please feel free to chat them in now.
And if not, you can offer them back to Brianna here, and you know, we could get back to you that way too if something's.
Okay, I appreciate it. Yeah, that's great. I appreciate that. Yeah, so that's a great offer. I appreciate that. So as you're looking through the tool and thinking about these things and asking these questions within your work team, within your agency, then you can certainly email us at pda@ccsi.org, and we'll get them over to Dr. Stankitis so he can provide his expert perspective.
But I won't tell you how to negotiate with my organization directly, okay? It's the only caveat there.
If we know your best practices, I think we might have a good sense of what you're looking for. We do have some questions coming in. What does the business agreement need to include in order to ensure that your MOU or BAA has the PHI language in it?
There's a boilerplate version of BAA that the federal government's got, and I think it's in the Federal Register, or, you know, talk to one of your attorneys. I mean, that's where it's going to have to be ultimately. I mean, before you sign anything, it needs to have legal review. But there are standardized BAA templates out there that people can go and acquire, and it meets all the requirements.
If they have a compliance officer,
yeah,
that would be a place I would start.
I mean, does MCTAC have that available? That might be one way to do it.
They have a boilerplate, yeah, but
I'm not sure.
Don't know that.
But that would be one thing to look at potentially. But it's out there. I mean, you can probably Google it, and I mean, the federal government's big on that.
Yeah.
I mean, it's out there.
Yeah, like sort of a follow-up question about what specific PHI guidelines would need to be included, but I think that kind of...
The BAA pretty much like covers it. They get into in terms of what if there's a breach. Let's just say somebody in your organization has made copies of somebody's personal health information. They're traveling to another location. They get in a car accident, and those papers fly all over the place, and they can't retrieve them. How are you going to deal with that? It gets into the management that if at the time of the termination, what happens to the PHI-related information for any of the clients that you're serving, how is it disposed of? It really gets into it, but really the federal government's boilerplate template has got a lot of that in there.
Great, thank you.
And it's compliant with the federal laws.
I appreciate that. And then specifically, I guess, to the point about this might be something that MCTAC could provide a link to or resources for. So we'll take that back to MCTAC more broadly about whether there's some resources that can be provided there. Another question for you. There's a lot of questions coming in, so I'm having a hard time following. Do you think, in your opinion, would it be beneficial to speak with the prospective VBP partners about the type of arrangement you want, or should you wait for them to ask you?
Again, if you want to have a win-win situation and you want to have a really wonderful partnership, it wouldn't hurt to sit down with them and see what their thoughts are, what your thoughts are, see what, I mean, they could be congruent right out of the box, it really shouldn't be, I mean, from my perspective, one of the worst ways to do this is to make it a tennis match where, okay, I come up with something and I pound it over to you, and then you do something and you come back. You're better off sitting down. What would work best for all of us? Here are our needs. Here are your needs. Here's how much risk that I'm willing to assume if I want to assume risk. This is where I think it has to be more of a collaboration, and I think that works out a lot faster too. I mean, you could have attorneys messing around with stuff for months on end and you never get out of the box to begin with. And the people that suffer are the people that everybody wants to serve. So
you gave a lot of advice for CBOs, and then there's a question kind of concerned about a rather small, like a small tier 1 CBO. How are they supposed to get the legal expertise that they need to be able to enter into these types of contractual agreements? So you made a comment about creating an LLC to protect against adverse tax liabilities. That requires legal, financial, and tax expertise that most CBOs don't have access to, particularly the smaller ones.
I don't know what to tell you there. I mean, I think, well, if you're a not-for-profit, I'm sure you have a board, and I think that some of your board members might either themselves have the expertise or might be able to help you find someone that would help you out pro bono for this. Because, again, if it's a real worthy cause, and if you're an organization that's a not-for-profit, I think there's some people out there that would be more than willing to go and assist you. Certainly you don't want to go to your future partner and saying, look, can you have your legal people look at this? That's kind of a conflict inherent in and of itself. But that would be the approach that I would take if I were running a small CBO that was a not-for-profit. Yeah.
So this is a question about how to talk about sort of populations that might take a little bit longer to reach their outcomes. So with a specialized population, for example, deaf people, this person obviously is an expert in that population. They know that providing services to them takes longer. They come to counseling without the background knowledge about the purpose and process that they need to be successful, and so they have to do kind of pre-therapy to prepare their clients to be successful. They feel like that might put them at a disadvantage compared to other populations that are served by other types of providers. So in a VBP contracting arrangement, how would you suggest they handle talking about their perhaps more difficult to serve populations?
Well, if you're talking about that it's going to require you more resources financially, time for say, a care manager or somebody of that ilk, you build it into your cost structure. I mean, this is, again, why you need to analyze and figure out what does it really take for you to deliver the service that you're proposing to your future partner. Again, the thing is, the worst thing to do is to underprice yourself, and you're running into it. So, I mean, particularly like for the deaf and hard of hearing, I mean, you're going to have to get into potentially ASL, all sorts of other things. Bake that into your proposal. I would really encourage you to do that. I mean, again, you got to think broadly. What is it, if I'm going to deliver a service to the best that we can, optimally, what is it going to take to do it? And you need to price it out. And again, don't ignore your administrative costs. They're out there too. They're for real. People have to pay for rent, heat, lighting, and all that. It's got to be factored in there if you're going to be doing this right.
Great, thank you. Thank you all for submitting very rich questions for our conversation. Again, I'll just say if you do have more questions that come up, if you think of things as you're working through the tool or reviewing the slides with your team, please feel free to email us and we'll pass it along. And I'm sure if Joe can't answer it, he will provide a response and we'll get it back to you. So please let us know if you have any further questions and register for the in-person event, but we'll talk more about this. And I think that's our last slide. So enjoy your afternoon and thanks for joining us.